Is from India and stuff are trying to join right now. But good morning, good noon, good afternoon, good evening from all quarters of the world. My name is Davis Thomas. A few things about me. I started learning orofacial pain pretty deep back in 2004, 2005. So this is my 20th year. Um, Learning and one thing that Lucas said is really resonates with me, that we learn throughout our lives. Until we die we should be learning. That's what I've done, and by God's grace it's worked so far well for my students, my mentees, my colleagues, people who publish with us, and of course clinicians around the world. So I love learning. I have a couple of degrees after my name, which I did some years in it. And orofacial pain is my passion. Medicine is my passion, actually, and OFP comes as part of medicine. So, um, again, Lucas has mentioned about the full 150-hour course. This would be just a dusting of that course, in an hour or less. I will try to impress upon you. If you can learn pain management, if you can learn fundamentals of pain, the diagnosis, the definitions, and how to really differentially diagnose each case, then that'll be our best reward. I'm going to share screen, and it says sharing is not turned on, Luca, yet. So I'll wait until sharing is possible, and I think now it's allowed. So I'm going to go to my first presentation. There'll be a presentation of 3 series presentation. So this will be just a little potpourri, just a little look up at differential diagnosis in the newer specialty in dentistry, at least in the US. And a lot of other countries, this already been a specialty. Um, by the way, these masters, one is in orofacial pain, one is in sleep medicine, and one is in headache pain management. This is from Edinburgh. They have a headache pain clinic, so this is from there. This is University of Sydney Medical School. This is from Rutgers. This is from New York University. This is from India. And currently, I'm in a PhD program for pharmacogenetics and pharmacogenomics, specific to pain and substance use disorders. Um, there's nothing to disclose. I have no payments from this program, nothing like that. In India, the Sanskrit of this is, it says Tamasoma Jyotirgamaya, which means the light of knowledge eradicates the darkness of ignorance. Um, I'll pause there for a few seconds. You can follow if you want to, and we post cases time and again, and you can actually take a picture later on too. I'll post this again. So, for us to talk about pain, we have to understand a few things, just differentiate some things. One is called pain threshold, and the other one is called pain tolerance. Threshold is the how much stimulus should I give to elicit pain? And that's different from from person to person. So if I take a little pencil and sharp edge and I just touch it gently, probably it's not pain. But so for some people, even that is pain. So their pain threshold is less than probably mine. I can tolerate, so that's tolerance. I can tolerate pain. If you look here, by the way, someone wants to do an MRI on this case, just be my guest. Um, I don't know what they do to themselves, but if you look at here, these are religious gatherings that, I mean, this hook is going through the flesh. What makes them tolerate pain like this? I mean, or are they not feeling it? What makes this people, this is actual blood, and everything is flowing down. What makes them tolerate this level of pain? They're whipping themselves to pain. And meanwhile, I'm trying to control stage 5 of pain or level 5 out of 10 of pain. Look at these things. This is India. This lady has a little thing pierced right through her cheek, and she's going to walk on this fire bed. Uh, This one is from another, I think it's a Muslim country, and they are actually swording their heads, and this is blood flowing down. This guy has all these pokes through his flesh. This is a coconut being hit on the head. Their pain threshold must be high, high pain threshold. So I don't generalize any of these. There's one condition called congenital insensitivity to pain. What happens in this case? You don't feel pain. And in a larger course, we can discuss, what these, I mean, it's not the purview today for this 45 minutes or so. So what, what is this condition? Why is this patient chewed off half of his tongue? Because pain is protective. Pain is defense mechanism. Once you touch a hot plate, you know not to touch it again. This is the key. This disfigurement, it looks like they had leprosy or something. They don't. As a matter of fact, leprosy, that's what happens. The bacteria don't eat flesh or bone. The bacteria just numbs it up forever, and then they don't they don't feel pain anymore. So when they close their hands, fingers in a in a car door, they don't feel it. So they injure. When they touch a hot plate, they don't feel it. So pain is defensive. Congenital insensitivity to pain. So sensitivity to pain is different levels for different individuals. We dentists, we must understand this. Some patients might not complain of pain until the damage is so big. Some of them on the other spectrum, just when it starts to hurt, they might tell you. So what are the red flags for dentists in pain? Number one, the patient has been grinding her teeth. Let me tell you something about this, right? Grinding, which is called bruxism. There's so much literature written in the last 30 years. 30 years or 25 years. Let's take 25. So much literature written up. But if I take a dentist in 2000 and then I see what the dentist is doing for the so-called bruxism, he puts a plastic plate in upper teeth, lower teeth, maybe both, maybe some muscle relaxants. And other than the fact that there's so much of literature that has come out, 2025 to 2026, that's our purview, 26 now, because we're going to continue this in January and February. What do we do still? Still the same damn thing we did 30 years ago. There was absolutely no clinical relevance for most of this research that's come out. 100 papers published, 200 papers published. What happened? So as a clinician, and I'm a pure clinician, and I love research in clinicians, as clinicians, and some basic science research I like. We want to look at how do we address this bruxism? Not by this classification and papers and publication and statistics. I don't care. I do care about you as a dentist, as a full mouth rehabilitation dentist, as an orofacial pain specialist. How do you address this? That is our purview. Patient feels the jaw tired on chewing. They say, I can't open my mouth, Dr. Thomas, for your cleaning visits. I used to be general dentist for 25 years, aesthetics and general dentistry. Why is the jaw tired for this patient? You have a golden opportunity to look at that patient when the jaw is tired, do some blood tests, and save a life. That is my supplication. That is my imploration to all my dental students and colleagues around the world. Let's take medicine of dentistry and let's look at these cases. If we think that's just jaw tired and we put a little jaw supporting plastic thing and a rubber thing in the mouth, we lost that. We lost that opportunity already. Patient says, many dentists have adjusted my bite, and grinding is a habit. This is the things we hear from dentists and from patients. Um, my jaw feels tired even with a short time. Not even chewing, just opening the mouth. This was something I published in Rutgers News. Rutgers is where I work. This is my main university that I teach at. And If you have a patient in your chair that is scheduled for 5 tooth extractions or 6 or 7 full mouth extraction, and he sleeps in your chair, is that something you should worry about? I think you should, because that is probably the first patient I would pick up and say, this patient might have obstructive sleep apnea. This patient might have imbalanced sleep or bad sleep. So, what is this orofacial pain? How did it become my peeve, my craze, my passion? How did it become? What are the differential diagnoses you have in orofacial pain? There's a small group of, I mean, a lot of patients come up with so-called TMD, TMJ. I mean, the word TMD is a trash can. Temporomandibular disorders. I mean, it's really nonsense. If you think about medicine, medical folks don't call it orthopedic disorders. They call it disease or condition. And this is all we have, even now in dentistry. We call it TMD. For me, it's a big trash can. Let's rewrite it all and let's start treating these patients, managing these patients. So musculoskeletal pain, muscle pain, skeletal pain, bone pain. We dentists even say to our patients, you have TMJ. Um, it's really a bad thing to say to a patient, please. A patient sits in my chair and say, Dr. Thomas, my dentist referred me to you. He said you have TMJ. I said, yeah, you have TMJ, two of them, one on the left side and one on the right. I mean, what level have we grown when we tell a patient, Miss Jones, you have TMJ? Let's take it to the science and medicine level. TMJ is temporomandibular joint. It's nothing. TMD, temporomandibular disorders. It's a trash can. I hate these things. But let's look at more in medicine. Now you have neuropathic, you have trigeminal neuralgia, neuropathies. These are the older terms even now. And I'm not really a fan of terminologies because they change time and again. But I want those entities that I can help my dentists, my dental students, my mentees, our followers in pain management. I can empower them to treat these cases, to manage these cases. Neurovascular. Wow. Now we're looking at nerve and blood vessel. So the question I ask dentists is, you know, is it possible that neurovascular, which is migraine, neurovascular, the best example is migraine. Can migraine come on the teeth? And the answer is a resounding yes. Okay, it's yes. Migraine can come on teeth, and it looks and it feels like a toothache. So the untrained dentist will treat this as a toothache. They'll blame on the jaw, they'll blame the TMD, but let's take medicine and let's say if it's a neurovascular pain, can I be able to diagnose it? Again, in a larger course, we can go over that a little bit more extensively, but please understand all throbbing toothaches are not toothaches. There are non-dental toothaches that look and feel and present to you and I as toothaches. Pounding tooth pain looks like pulpitis, but it could be a headache that is coming on the teeth. Then there is TACs, trigeminal autonomic cephalalgias. Big name. It just means that the pain is in the trigeminal distribution, V1, V2, V3 distribution. There are some autonomic features. You can have some eye tearing, some sinus congestion, some color changes on the face, some sweating, salivation, and 100% of these entities, there are like 5, 6 entities under them. Let's say 6 entities. All of them look like and feel like TMD pain, and all of them, almost 100% of the time, will be misdiagnosed as TMD. By who? By us dentists. We need to stop that. And education and knowledge is power. So this will be our power to take the medicine of TACs, trigeminal, autonomic, cephalalgias. Cephalalgia is a headache. Non-odontogenic toothaches. This is the biggest circus in dentistry. We are not trained well in dental schools. I was not. I went through 3 dental schools, and I was not trained well in pain management, except when I took a course and then fellowship and then master's specific to pain management. Then we excel in it. We start excelling in it. So non-dental toothaches that are not actually from the tooth. These are the biggest blunders in dentistry. Let us correct it. Let's help our patients. Let's help ourselves. That's the scope of OFP. Then we have snoring and sleep apnea, which is always a killer. Sleep and pain, how does it affect each other? Systemic factors, like Dr. Lucas mentioned it, Dr. Lastman mentioned that. This is my peeve. Systemic factors that affect your dentistry, systemic factors that affect the prognosis in dentistry, systemic factors that affect pain. And I am doing my diligence in it as much as God allows me to. And by God's grace, we are successful. And I'll transfer that knowledge to you with no issues. And then research. Look at this case, right? This case is sitting in front of me, having visited approximately 11 or 10 or 11 dentists. And she's complaining about pain on this tooth, upper left central tooth number 9. In the US system, you can name it in the FDA, whichever system you follow, no problem, tooth number 9. And let me tell you, she wants this extracted because she had enough of this. 11 dentists have seen this in the state of New Jersey and New York, have seen this patient. And she's had enough. She said, I want this tooth out. Let me tell you what, when you look at the panoramic radiograph, this is not taken by me. This is what the patient brought me on a little cellophane paper. I mean, it's actually there, printed out. And I took a picture of that. Her entire right side of the face is converted into implants. Is it possible to have dental caries or periodontal disease on one side? There's no history of trauma, nothing at all. There's zero trauma here. No other reasons. What makes us dentists to do this type of nonsense to our patients? It's really depressing to see that this patient complained of pain for 3.5 years. And all dentistry in the East Coast that this patient went to could do is blame it on the teeth, extract more teeth, deep cleaning, scaling, root planing, graft, extractions, and root canals, episectomies, and then this is what she looks like. I think it's, 4.5 years of agony for this patient. This patient has spent around $30,000. $30,000. I mean, how do we explain this foolishness to the patient? This is why orofacial pain should be on the top of our agenda to learn. There's no way there can be caries or periodontal disease on one side of the face. It does not happen. So what happened in this case? This case is the best example of a mess up in dentistry because we don't teach our people. We don't teach our own folks that pain we need to learn separately. And that is my mission in dentistry in orofacial pain. This is not the tooth causing it. This is non-odontogenic. Non-odontogenic. This one here. Non-odontogenic. So I'm going to give you a take-home message. If you cannot reproduce the pain from that tooth, which is this tooth right now, do not treat that tooth because it will be wrong. You must be able to, if it's a toothache, you need to be able to reproduce the pain from that tooth. If it's not reproducible, and not any pain, but the patient's familiar pain. Familiar pain. What does that mean? This is the pain that the patient is complaining about. This is the biggest blunder in dentistry that we have carried over 20 years of literature that I have on this. Plus, so familiar pain is not reproduced. Do not touch that tooth. We are about to do the wrong thing, wrong diagnosis. If you cannot reproduce the pain, don't touch the tooth. You can do palliative treatment, maybe a little painkiller, but you should not enter that tooth. This tooth is not the cause of this patient's pain, but she wants this extracted. She's pointing it out to that tooth, but that is not for the patient to decide. That is for us as clinicians to say, hey, I cannot reproduce cold, hot, tapping, shaking. Nothing reproduce the pain from that tooth. So, bullet point, clinical pearl number one for you if you are a novice, a newcomer to orofacial pain, I want to tell you, if you cannot reproduce the pain from the tooth, number one, don't treat the tooth, don't do the root canal, don't do extraction, no graft, no implant. Look for non-dental causes of the tooth pain. I will save a patient's life, a family's life, and save your career too. So what is it? This is a pain from a muscle referred to the tooth. A pain from a muscle referred to the tooth. So clinical pearl number 4 for you all listening today. If it is not the tooth, it is a muscle. In that hierarchy, non-dental toothaches have a hierarchy. If it's not the tooth, it's a muscle. We will teach you what muscles refer the pain to the teeth. And this is the biggest mistake blunder in dentistry. And we have gone back to 20 years, 25 years, brought up and dug up those cases. And dentists are good people, but we are not trained right in pain management. So what causes this entire circus to happen from 10 to 11 dentists, all specialties involved in here? Or you can see that even the type of implants are different. So two different people did two different implants. Types of implants are different. This is the circus in dentistry. Let us stop the circus. Let's learn the medicine of dentistry, and let's say we can do it so that physicians don't look at us and say, hey, he's just a dentist. I hate to hear it. We're going to take the physician of the stomatognatic system back into dentistry, and we're going to say, we will do it. We know pain management. We don't want to go through this circus. So if it's not the tooth, it's a muscle. So what muscle made this dentist to do all this circus? The masseter. This is our main clencher muscle. These are the trigger points inside these muscles. And what do? They refer pain not only to the maxilla, so the ENT folks will see it and say, oh, I think it's sinusitis. No, it's not. This is pain from the muscles referred onto the teeth, the lower and upper teeth. So you can see what happened to this patient. All of this was unnecessary. All of this was patient butchery. Unfortunate, but true. And again, I don't blame this dentist, but once you listen to a lecture like this, you should still continue to do it. What level have we grown? So now we see the masseter muscle, the major muscle that causes this type of circus in dentistry. So, but the patient is complaining about what? The front tooth. So if it's not the tooth, it's a muscle. So what muscle is in the front tooth? The temporalis muscle. The temporalis muscle, especially the anterior temporalis, refers to that tooth. So all this circus that was done by 3-4 dentists on this tooth, they trimmed it out of occlusion for no reason, is from the temporalis muscle. So clinical pearl number 5. Upper teeth, if you cannot reproduce the pain from the teeth, you should look into the muscle. What muscle? Temporalis muscle. Temporalis is the only muscle really that I'm thinking of that refers pain anatomically. What does that mean? The anterior temporalis, so in orofacial pain, there is the anterior temporalis, there's the middle temporalis, and there's the posterior temporalis. So temporalis muscle, the anterior temporalis refers to the anterior teeth, the middle temporalis refers almost to the middle teeth, and the posterior temporalis refers to the posterior teeth. Now you can think of those patients who complained of jaw pain and sat there and you took a panoramic radiograph, you saw the wisdom tooth impacted, and we think that's a wisdom tooth. Completely impacted wisdom teeth cannot cause pain. What is one mechanism? Not one single mechanism. Completely impacted tooth. How can it cause pain? Where is it written? Where is the literature? So is it that the wisdom tooth is causing pain, the impacted one, or is it that the muscle is causing pain? Highly likely, this is the one causing pain. Not, we'll teach you this, okay? So what was the myofascial referral? Myo means muscle. Fascia is the tissue that connects these muscles together. So myofascial trigger point pain. Myofascial referral. This entire circus, by the way, none of them had decay on them. This was another circus done even prior to this circus here. Unfortunately, it's too late for me. I cannot correct this. What is done is irreversible, but at least the extraction and the implant and the graft on this should be prevented, because that is not the tooth causing the pain, it's the muscle causing the pain. So, clinical pearl number 6 or 7 for you to take home. What are the sources of non-dental, non-odontogenic toothaches? It's interesting, right? In this hierarchy, if you cannot reproduce the patient's familiar pain from the tooth, do not touch the tooth. I'll repeat it. If you cannot reproduce the pain, with hot, cold, tapping, percussion, clenching, whatever, you cannot reproduce the pain from the tooth, please let us not touch the tooth. So what are the non-dental causes for tooth pain? Number 1, muscle, myofascial. Number 2, nerve. So this is muscle, this is nerve. Number 3, headaches, migraine, let's say, okay? Or tooth migraine, facial migraine, mid-face migraine, yeah? Other structures, sinus, heart, rare. Psychogenic, no. Um, I know once I started learning this science, in the last 20 years, I have not seen a psychogenic case. If you and I as dentists look at a case and think it is psychogenic, please let us understand the only psycho in the room is me. Hmm. Me, the dentist who thinks it's psychogenic. 99.999% of the time, it is the patient is real. We don't know the reason, so we brand them as psychogenic. Okay? Because I cannot find out. My knowledge is limited. I say, oh, I don't know what it is, so therefore you might be the psycho. No, I am the psycho in my room. So until 2005, I used to see psychogenic cases all the time. 2005, I joined Rutgers for the orofacial pain with Dr. Eli Elia, my mentor, who hopefully will be there in Poland at some point. Eli Elia. So I learned it from him and other faculty that has been there. And I found out, my goodness, the psychogenic case, I thought there was crazy patients are not crazy. I'm the only crazy idiot in the room. Their pain was real. I did not understand it. I could not diagnose it. So therefore, I called it psychogenic. So the next time you see a psychogenic or mysterious case, let's talk a little bit. Look at the case number 2. We have all seen these cases. Multiple root canals on the lower teeth. What a tragedy this is, huh? These teeth have no decay at all. These are American trained dentists doing this. So it's not different in Poland or Australia or any other European country. Nothing is different. If you cannot reproduce the pain from these teeth, you should not have done the root canal. I mean, this is a complex one with 2 canals in there. You see that? What a tragedy this is. This is called, unfortunately, this is called butchery. Okay, like a butcher cutting meat. None of this was because of a tooth. So again, our paradigm I'm giving you when you go home to the practice Monday morning is this. If it's not the tooth, it's the muscle. So what's the first reason for non-dental toothache? So which muscle is this? This is the anterior digastric muscle right in our throats, right? This muscle with a trigger point like that, and we will teach you trigger points, we'll teach to inject trigger points. All this stuff is coming up, but I'm just saying, if it's a trigger point here, it refers to the lower front teeth. What a beauty if you learn medicine. I was in Poland a few months ago, and I said this sentence over and over again. What a beauty if you know medicine. I mean, the referral pattern from this is so obvious in medicine, and we dentists are not taught the right way for pain. And look at this one, not just the teeth, the labial aspects of the bone and the gingiva. You know how many implants and grafts have been done for this case? It's just unbelievable what we do. Not knowing, dentists, again, I don't blame a dentist. We are good people. We want to do the right thing. It's just that we are not taught the right way for pain management. That is what we want to change. And I hope to change that in some way, my humble way, in Europe soon. Look at this case. This one, the pain is in the lower labial gingiva, right here. And the specialist, I won't mention what specialty it is, specialist said it must be subgingival calculus. I wish I had clean gums like this and teeth like that. It's beautiful. So just because we don't know doesn't give us the right to label it either as psychogenic. This poor thing was labeled as psychogenic. Look at the pain, burning pain, dull pain. Patient is very clear. And what did the specialist say in this case? Let's open up a flap. Are you kidding me? This is as healthy as the gum gets. Look at the beauty of this gum here. I mean, you can see the little trauma here, the little festooning, the little lifesaver shaped. That's nothing. This patient should not be touched because we don't have a diagnosis. So, clinical pearl again, number 7 or 8 or 10, whatever. If it's not the tooth, it's the muscle. Again, what muscle is this? Digastric muscle, okay? Lower front teeth. What can we do? Well, with the ultrasound guidance, we can actually inject the digastric, and guess what happens to the tooth pain and the gum pain? Disappears. It's gone, kaput, it's finished, gone, okay? So this would have been a disaster waiting to happen, just like this. But fortunately, someone a little bit more trained in pain management saw the case and said, stop it. This is not the teeth causing this pain. Look at what happened here. This is root canal crown, root canal crown, root canal episectomy and crown, root canal crown, all because of one spot. This is actually the treatment we do. This treatment, we'll teach you this. This is the little stent, like an acrylic stent. You can see the stent sitting on the teeth. Okay, this has some medicine underneath it. This is the patient showing her own. Look at my stent that was done. A small little area like that big can cause pain on all those teeth. Okay, this is the level of education we need in dentistry. What makes a dentist do this type of butchery to this poor patient? Root canal crown, episectomy, root canal episectomy, and crown. And then this is supposed to be extracted soon. Don't touch the tooth if you cannot reproduce the pain from the tooth. What caused this mess? The temporalis muscle. Can you imagine? Poor thing, huh? This muscle referred to these teeth and they were killed. The middle temporalis referred to all of these teeth and they were all killed. And in the process, the patient had a small little, what we call traumatic neuroma. Big term, small little thing. A nerve that was healing right there. So now the patient has two problems. All the teeth were now treated irreversibly, sort of what I call butchery. Plus, now there is a nerve lesion there also, because secondary to the treatment. This is a mess. This is why orofacial pain is the king, teaching it. So there are so many of these nerve issues that we dentists will see. This is the one that I want to tell you what is pre-trigeminal. We all heard a little bit about trigeminal neuralgia, but I'm going to tell you a little bit about pre-trigeminal because that is where us dentists can stop this circus and say, hey, listen, we know this material. By the way, in this case that we just showed you, this area under this little plastic thing, that is this diagnosis here, traumatic neuroma. It will put that patient in pain on the entire segment. And it's not difficult. You can treat it if we have the knowledge. So what we were talking about pre-trigeminal neuralgia. Look at this case here, right? This patient, I dug up these cases from old charts. He goes to the dentist saying, lower left side is hurting, doctor. And what does the doctor do? The dentist kills this tooth. Finished, root canal. And he does a composite bonding on this too. He thinks the little an amalgam old filling can leak. I mean, can amalgam filling leak like that? I mean, is that causing pain? What is the mechanism of a leaking amalgam filling causing pain? What is the mechanism? See, we dentists should question everything that we are taught. in our so-called literature. Why should a leaking amalgam hurt this patient is my question. In any case, that was not asked. This was changed into a composite bonding. They killed this nerve. It's tragic, tragic. They killed the nerve. And then the next dentist looks at all of these. Patient still has pain. So what does he say? The metal post that is in this should cause the pain. That's why. And he changes this entire crown and this to a transparent post. Folks, dentists, what level have we grown in medicine? This is why medical folks look at us and laugh. Let's stop this, right? If you cannot reproduce the pain from this, so what is happening here? This case is pre-trigeminal neuralgia. Pre-trigeminal neuralgia. It's a neuropathic pain. It's a nerve condition. So what is pre-trigeminal neuralgia? None of this was necessary here. None of this was necessary because months later, the patient showed up at a neurologist and said, my face is on fire. What does the neurologist do? Treat the patient with anti-epileptic medication. That should have worked right here. What a tragedy. What would this 68-year-old have told us? You guys really did all this with the wrong diagnosis. It's a tragedy. So what is pre-trigeminal neuralgia? I'm giving you the bullet points. It's a female, more common in females, 30 to 50 years of age, 30 to 50 years of age. The tooth will be normal, really. Tooth will be normal. It can be aggravated by cold. When it's aggravated by the cold, what will the patient say? Uh, when I drink cold foods and eat ice cream, what would the dentist think? It's dentine exposure. That's all we have taught. We need to teach ourselves a little bit differently, a little bit higher. So please, let's learn it together. And sometimes they say, I have a little aching. We were not taught this in dental school. I was not, and most dental students are not. It can be throbbing. What does it look like? A toothache, right? It looks like a tooth, but it's not a tooth causing the pain. It's pre-trigeminal neuralgia. Sometimes in the US, they come and say, hey, doctor, that tooth that you did last year, I felt a little zing, a little flicker of pain, and then it goes away within second. That is pre-trigeminal neuralgia. We should have treated this case with respect, but instead of that, we did not know. So these dentists who saw this case really butchered these teeth. Unfortunate, but true. So let's do this. Pre-trigeminal neuralgia, okay? And then look at this one, right? This is from the medicine part, right? New England Journal of Medicine. This is the type of education we need. Look at this one. Eye movement can cause this pain. The patient will be told that you're crazy. It's not true, but it's true. Eye movement can cause trigeminal neuralgia type of pain in the teeth. Tongue movement can cause pain. Laughing can cause pain. Raising the voice can cause pain. Pronouncing labial letters B, M, B can cause pain. That's trigeminal neuralgia, pre-trigeminal neuralgia. Flexing the trunk forward, the trunk forward. Yawning can cause pain. Head movement can cause pain. Jaw movement can cause pain. Blowing the nose can cause pain. Swallowing can cause pain. None of this is taught in dental schools. So we really end up in treating these patients not knowing, but we are innocent of not knowing. But listen, ignorance is not an excuse. We have to learn ourselves. We have to teach ourselves. That is why these type of courses are so important, so our patients don't suffer like this. Case number 5. Wow, this was the case that really I mean, we have so many of these cases, but it's just sad to see. Look at this case, 65-year-old female, right? Pain, face pain, and occasional numbness. Clinical pearl number 11 or 12, I'm giving you. If a patient ever says numbness, please work up that case in detail. TMD cannot cause numbness. TMJ doesn't cause numbness. And grinding and bruxism, all that nonsense doesn't cause numbness. Numbness means I have to stop, I have to evaluate, and I have to think about it. Could be a worst case scenario. Look at this case. How many dentists, pain and numbness on the face. All of these things are happening to this patient, right? She has 4 years ago, she had breast cancer, and that was diagnosed, and then they did mastectomy. Then they treated her 5 years ago. And 4 years ago, they did a PET scan and told her everything is good, right? So she never went back, obviously. Uh, it's so many red flags. I will describe this to you at some point. Hopefully, we'll teach you all this, but so many red flags. Long story short, this case was treated as TMJ, TMD, upper appliance, lower appliance, all the plastic plates you can think of putting in the patient's mouth. And then I saw the case and I said, hey, something is not adding up. I don't like this. Patient has numbness. I don't like the duration of pain. I don't like bilaterally. It looks like trigeminal neuralgia. Ordered an MRI. What is in an MRI? Her old breast cancer sitting right inside the brain, eating it away. This patient has 1 year to live. What will we tell a patient's family when dentists, bunch of them, did some plates and some muscle relaxants for this patient? Numbness is never a good thing. If they have numbness, let's look at it. Okay, and we'll describe in our courses a lot of reasons for numbness: local numbness, regional numbness, systemic numbness, tingling. Everything we'll teach you. Okay, hopefully you get a chance to learn. This is cancer sitting inside the brain. It has actually eaten up the entire petrous temporal bone. Okay, there's nothing you can do for this case, and this was treated by plates for bruxism. I mean, seriously, we published the case. When we publish the case, it's a problem. This is the metastasis of the cancer to the petrous temporal bone inside, and the patient did not survive for probably a year. This is from a textbook. I will not show you what textbook it is. And it shows TMJ examination. What level of stupidity have we grown? This is not even this is not even close to the TMJ. The TMJ is right at the tragus of the ear, the tragus. I mean, this is a textbook. This is the level we teach our students and our dentists. I mean, shame on ourselves, right? So again, this is not at all. This is probably the master they're looking at. It says TM joint examination. 15-year-old, 15-year-old with pain. The poor thing has gone to so many dentists and physicians. And this poor thing is now, of course, what is the dentist diagnosis? TMJ, TMD. You know what the patient is doing? It's a little kid. He's injecting himself with a drug called tramadol. Tramadol. There is so many physicians and dentists and surgeons and psychiatrists and pulmonologists, ENT and pain management has seen this poor thing. I'm not better than any of them, but I know that I'm going to put my mind to teach you this stuff, and this changes this kid's life, this child's life. He's only 15 years old. It changes his family's life forever because he stops going to school. And the dentist, what do they know? They said it's TMD. It's not TMD at all. His entire head is hurting. He cries out in pain, tries to take his eyeball out. We found out what this was. Doing the entire workup of a case, that is what I would request all of us to do the same thing. Let's do the workup of these cases. This is a neuralgia case. I showed you neuralgia, occipital neuralgia, nerves coming out of the head right here, causing pain on the TMJ because the ear, the end of the ear is supplied by the C2 nerve, the cervical nerve. No dentist, if they are not in the orofacial pain, will know this. And then neurologists in India invited us to publish this paper. This is important. We can impress our medical folks saying, we can do it. We can do it. If we put our minds to learn medicine, medicine of pain, medicine of dentistry, we can do it. We published the paper. This little cyst is not causing any of this pain. They removed the cyst also, not causing pain. So this is entrapment neuropathy. Entrapment of nerves in different areas of the head and neck can cause facial pain, tooth pain, or both. So please let us understand that. Look at this case, right? When do we stop butchering these cases? This is my mentor, Dr. Eli Eliav's slide. I mean, I don't know. I cannot begin to tell our community, dental community, why are we doing this? What makes us think that this is our toothache for 28 teeth? Thank God the wisdom teeth are missing. Otherwise, some dentists would have drilled into the wisdom tooth also, probably. Thank God. So we need to educate ourselves, and that is why we are bringing these type of programs to India, to Dubai, to New York, and every other country and the state we know of. Okay, so again, I want to emphasize a couple of things here. Um, Wisdom teeth causing pain. Please understand, there is no such thing unless the wisdom tooth has a communication in the oral cavity or has something like an ameloblastoma or something, which is not hard to see on a radiograph. Wisdom teeth, impacted wisdom teeth cannot cause pain. What is the mechanism? We just said this. We are foolish to say it. Wisdom teeth causing anterior crowding. Can you imagine this type of nonsense? Wisdom teeth cannot cause anterior crowding. What is the mechanism? You know, if we are in pediatrics and other things, in orthodontics, we know that if the baby tooth is lost early and if the mucosa gets thick, the permanent tooth will not come out. So just by losing the baby teeth early, the mucosa is thicker on that lost edentulous area, the permanent tooth doesn't come up. Can you imagine this impacted wisdom tooth in the corner of the mouth? Remember, teeth don't even have the force to come out through thick mucosa. It cannot come out through the thick mucosa. The same tooth sitting on the corner of the mouth, pushing all the teeth forward. Those impacted teeth to have to do pushing all the teeth forward to cause anterior crowding, they must be Arnold Schwarzenegger. I mean, how much strength do they have? All nonsense. Occlusion causing TMDs, another biggest blunder in dentistry. Occlusal changes, occlusal discrepancies, class 2 occlusion, this and that, and deep bite causing pain. What level is science grown in dentistry? Orthodontists, you guys, I know the best orthodontists in the US, we change occlusion every single visit. We change occlusion throughout the patient's orthodontic movement. And if they all ended up with TMD case and pain, what level have we grown thinking like that? So please let us not do this type of nonsense. Let us teach our community. Today, now I know probably 100 people have joined this course. Let's let's teach ourselves. How do we diagnose pain? That is what I'm going to teach you as the best I can. I don't cover up any knowledge. I'll give you everything I have because life is too short. God has been great to me. He or she gave me immense power to learn, and that is what I'm giving you. That knowledge that I've acquired over the last 20 years in orofacial pain and 40 years in medicine, that's what I'll give you. What are the reasons for scallop tongue? Why should the teeth be treated? Is that just grinding? No. Linea alba bucca, we thought it was normal. I don't think it's normal at all now. Posterior pharyngeal space crowded. We thought it was okay. Just finish it off. Let's do the full mouth rehabilitation. It doesn't work. Let's learn medicine. Okay. Role of occlusion in TMD, not there at all. As a matter of fact, I think many in Europe follow premolar to premolar. What happened in occlusal scheme? What happened to all those missing posterior teeth causing all the trouble in the world? It's not there anymore. It's not there. Clinical pearl number 12. Changes in occlusion don't cause TMDs. The occlusion of the patient that was born with cannot predispose to TMDs. As a matter of fact, our toughest cases in TMD are class 1 occlusion cases, not class 2, not class 3. So let's learn medicine, please. Again, I'm going to show you that slide again, sources of non-odontogenic toothaches. I have like 5 minutes, I'll stop. Post-implant, many of you will do implants, right? Post-implants, neuralgia, neuropathic pain. We map these cases, right? If you have cases like that with implants and with nerve damage, please reevaluate the case, put the patients on steroids. There's so much we'll teach you how to recognize it, how to reverse it if possible. Let's learn medicine. I'm going to skip through this because there's a lot to learn. These are the implant cases we get. That's so messed up, with post-implant nerve pain, post-implant tingling, post-implant numbness. We call it post-implant neuropathic pain. Case number 9, and then we're going to stop. And if there's any questions, I'll take. Case number 9. I will not read you this busy slide. Just understand this poor patient has been in pain for 23 years. Years, not months, years. When my student, well, he's a big prosthodontist in India, Dr. Rangarajan, he brought me the case. I said, oh my God, did you say 23 years? Yes. And look where we reproduce. Remember, the pain is reproducible from one area of this entire mouth. Look at the reverse curve. So dentists down the lane, when they see the reverse curve, they say, oh, bite changes, occlusion causes TMDs. What? Occlusion causing TMDs? I mean, come on. Let's make the physicians respect us for the knowledge in medicine that we have. This tooth pain, all the pains in all of these can be reproduced from this one spot. Is it in the tooth? No, it's in the soft tissue. This was my master's thesis, not this case. My master's thesis was something called traumatic neuroma. There's no inflammation, nothing at all. You press on that, the patient will have the pain continuously. Okay? Traumatic neuroma. We can treat it. We treated this patient. After 23 years of agony, Dr. Rangarajan and myself, we saw the case and we said, okay, let's put a stent. We made a stent. I'll teach you how to do all these. And we put a little bit of paste inside there, medicine paste, medicine. This is the spacer. And guess what? 95% of the pain is gone. We published this twice. This is Indian Journal of Prosthodontics, actually. It's one of the best prosto journals ever. Indian Journal of Prosthodontics. We published this. Why? Because we were teaching prosthodontists these things exist. It's not the reverse curve that is causing any of this pain, or occlusion doesn't cause pain. Okay? This is actual classic traumatic neuroma. We published it again with our mentor, Dr. Jeffrey Okeson. We published the case. We looked at why this case becomes so important for dentists to learn. And we published in one of the major journals in, I love publications. So when you guys become my mentee students, I'm going to take you through publication. Dr. Lastman is doing publications with me as we speak. And I praise him for that mindset and the ability to say, hey, listen, I want to publish. I want to see these cases. I want to learn more. I love that about him. So we'll make a great team. This is with Jeffrey Okeson. We published this case. We published how this pain is formed and the pathways of this pain. And this is my master's thesis, just so that you guys know, traumatic neuroma, okay, traumatic neuroma on rats and mice. We did a very high level of research on this. So I will teach you all of this, okay? And the last case I'm going to show you, same philosophy. This poor thing had one tooth extracted, another tooth extracted, another tooth extracted, all these root canals for nothing. This patient's toothache, forget this for now. This is, forget the imaging. This patient wakes up early in the morning and he has the toothaches. Is there any toothache that can wake up the patient early in the morning? There isn't. There isn't. There's no mechanism. And then this patient in New Jersey, he will go to the window in this type of winter. We have snow here right now. And for the toothache that bothers him on the maxilla, I love the balloons. He goes to the the window, opens the window and looks through the window and takes deep breaths, and it reduces his pain. If it was tooth sensitivity, would that cause it like that? No. It should increase the pain. So what is this case? And then if you look carefully, all of this root canals and episectomy is done for no reason at all by multiple dentists. This is not a toothache. This is cluster headache. Okay, a cluster headache is a type of headache that can come on the teeth, in addition to migraine. If we learn this material, we can arrange this and we can treat these patients. So Please learn this material and let's learn it together. So this is called trigeminal autonomic cephalalgias. Trigeminal because it's the trigeminal distribution. It's autonomic. That means you have tearing, salivation, sweating, color changes on the face, stuff like that. And you have a headache, cephalalgia. Cepha means head, algia means pain that comes on the teeth. So it's around 1 o'clock right now. I'm going to go to my last of the slides, and I want to impress upon you two things. Number one, learn systemic factors, please. Let's learn medicine. Look at this from Marshall Protocol site. We have all of these different entities connected with each other. Look at all these connections with each other. This is my peeve in medicine. As much as I can, I will teach you this. Throughout our courses, we will be focusing on not just the diagnosis of pain, management of pain, and TMDs. We will focus on how your health affects pain. All of these entities, this is just one small little segment I'm showing you. All of these can affect facial pain. All of them can cause TMDs, so-called TMDs. I hate that term, but that's all we have in dentistry right now. Hopefully it changes. All of this. And we can look at these and say, if a patient with psoriasis comes to you, if a patient with rheumatoid comes to you, if a patient with sarcoidosis, schizophrenia comes to you, scleroderma, by the way, scleroderma is not the term right now. It's systemic sclerosis. Are we equipped in medicine? Can we learn ourselves more? Can we teach us ourselves more? And I believe we can. We published these two already. Please look up this one. I published it with the pioneers in TMDs. Um, this is the temperamental disorders of current perspectives, and my third edition, which has just come out, my co-authors, and the fourth edition is on with Dr. Lucas Lastman, who will be in it. My fourth edition. And I want to see the fourth edition is failures in dentistry. So I want to see what failures do we have in our dentistry? What failures do we have in pain management? Why? Can we teach ourselves to make it better for us and definitely for our patients? I rest my case. I'm going to give you this. If you want to follow us for cases, you can do that. But in a larger course, we will be discussing all of these and much more detail. The next time we see each other will be in January. We will be doing TMDs and then followed by something in dental sleep medicine and Bruxism, the way I look at it. So we have 3 free webinars to make ourselves available and aware to our patients and for our patients. What is pain? What can we do? Can we do any better? I rest my case. Thank you for listening today on a Sunday. I know that you spent some valuable time with me. I love you guys. I love Poland. I've been there with Lucas and I loved it. I love the people. I was in Romania since then. This is our first attempt to spread this type of knowledge in Europe. We will do it succinctly. We will do the medicine of dentistry. I thank you all, and I look forward to working with you. Lucas or Jacob, if you are there, I will stop. Any questions also you can ask, no problem. I'll go back to the case if you have a question regarding the case. I don't know if you guys can unmute or ask, or if there is anything that I can answer live, please ask. I'd be more than happy to help you out. Lucas has written something on the... Okay. Okay, fine. Oh, the fellowship, please look forward to. We are coming to Poland for sure. I'm sorry I didn't mention anything about the fellowship. 150 hours I'm going to teach. I've taught these 150 hours in India, in Dubai, Middle East, and everywhere. 150 hours specific to pain, TMD, sleep medicine, dental sleep medicine. We're going to teach it. We're going to teach it to the fullest extent. I will not hold any information back, I promise you. Whatever I know, I will teach you. And these are the books. I don't get any money from these books, but I love the medicine. Okay. So this is what I submit to you. Third one is on its way to my home, third edition. Not edition, sorry, third edition, but different topics. We need to learn, man. We need to learn. So we will come to Lucas's place. I love the guy because he's so honest and he's an amazing clinician. I love the work he does in full mouth rehab. I'm going to be part of his programs. So we're going to come to Gdansk. I hope I pronounce it the right way. And we're going to teach you as best as we can. Please contact Last Minute Education and the seminars on Facebook and their emails. I don't know if Jacob can put information in here. Um, Share hello. I know that you said hello. So any questions, you can unmute. I'm not sure if you can unmute and ask. If not, I see you January again for the another 1 hour of some succinct education in pain medicine. And then again in February also, we'll do the same. Hopefully you all learned something new. Thank you for joining. And please contact Dr. Lucas's Lucas Education, Last Minute Education for the full details of our 150 hours coming to Europe for the first time. Thank you. Enjoy the holidays. Merry Christmas to you all. Happy New Year. If you're in the New Year's thing, Happy New Year. I will be seeing you in the new year. Take care. Be well. Bye.